Dear colleagues, it's a pleasure to participate in this meeting. My talk is about the evidence-based guideline on unexplained infertility prepared by ESHRE. So we will be reviewing this guideline in the next 20 minutes. Here you see the guideline development group, which represents a multidisciplinary, multinational, and even intercontinental group, because we prepared the guideline together with our Australian colleagues. We followed the well-established evidence-based guideline preparation methodology by ESHRE, which is available on ESHRE's website. What we first do, we describe the questions to be answered regarding effectiveness or safety, and then our research associate at the central office, Natalie, does a literature search by the identified keywords, categorizes them, then we assess the quality and prepare the evidence tables, include our own opinions in hours and days-long discussions, and we prepare a draft of the guideline, which is presented for stakeholder review worldwide for 2 months, and then the comments are reviewed and the final form is given and it is published. You can access it free of charge at the ESHRE website, as well as a summary of it published in the Human Reproduction Open, which is the open access journal of ESHRE. So let me review the terminology we've used in the guideline. If there's a strong recommendation in favor, that means from a patient perspective, the patients will want the recommended course of action mostly, and for clinicians, most patients should receive that recommended course of action, and for policymakers, it means it can be adopted as a policy in most situations. You can apply the same in the other direction when there's a strong recommendation against a course of action. And when there's a weak recommendation in favor or against, let's say, it would apply to majority of patients, but still a substantial proportion may not agree with it. And for clinicians, there may be different choices available, and they would need to spend greater effort in making their own decisions and helping make their patients to join this decision, make their own decisions. And for policymakers, it will require a lot of debate with the other stakeholders. So we divide the guideline to 3 sections. One about the definition of unexplained infertility. The other is how we arrive to a diagnosis of unexplained infertility, and then what's the recommended route of action for management. Let's start with definition. Here you see, when we first started working on unexplained infertility, it is a diagnosis of exclusion. So the diagnosis we came up with was infertility in couples with apparently normal ovarian function, normal fallopian tubes and uterine anatomy, including cervix and the pelvis. To rule out age-related infertility, we limited our work on women who are 40 years or younger, and to couples who have adequate coital frequency. The definition may vary slightly, we'll discuss later on. And the male partner should have normal testicular function, genitourinary anatomy, and a normal ejaculate. So the definition of infertility follows the ICMAR and WHO, 12 months of regular unprotected sexual intercourse before investigations are initiated. And we regard the regular menstrual cycle as one that lasts 24 to 38 days, up to 8 days in duration of bleeding, and shortest to longest cycle variation was less than 7 to 9 days based on this reference. And what we recommend to see, for seeing if a couple meets these definitions, in every case, routinely a medical, reproductive, and sexual history should be taken from both the male and the female partners. And there should be at least one basic semen examination using the WHO criteria by an accredited laboratory. If the results from this first basic semen analysis is below the lower fifth percentile, which is presented as the reference limit in the WHO manual, a second analysis should be performed like 3 months later to see if it's a personal abnormality, because semen analysis values fluctuate enormously. So there was the definitions we used to call a couple with unexplained infertility. Here, it's a couple's problem. Then how do we make this diagnosis? How do we decide if a woman is ovulatory? So which tests would be required? Actually, in a woman with regular menstrual cycles, tests for confirmation of ovulation are not routinely recommended. It's called as a good practice point because there's no studies looking at this, and there's probably no equipoise to conduct such a study. And as the guideline development group's opinion, that's our conclusion. If a woman has predictable normal menstrual cycles based on the former definition, then we don't think additional tests to confirm ovulation occurred is necessary. If for some reason you think it is required, you can use folliculogram, you can use urinary LH measurements, or a mid-luteal progesterone measurement. Is there a test that tells us the quality of corpus luteum? Quality is a pretty vague term, which I don't like really in the context, but in women who have regular cycles, who are assumed to be ovulatory, we do not recommend measuring serum progesterone levels to make a decision about, or to make inference about corpus luteum quality by progesterone measurement. Again, progesterone levels vary, and they don't necessarily translate to clinical outcomes. And there is no need to do an endometrial biopsy in the absence of another indication. Obviously, if you have reason to think she may have endometrial hyperplasia, if you need biopsy, that's a different story. But in a couple looking as unexplained infertility, there's no recommendation. Actually, there's strong recommendation against doing an endometrial biopsy. There are many studies showing that in phase, out of phase, etc., assessments are not relevant in the context. So how about ovarian reserve? There are always discussions about whether a low oocyte quantity reflects a lower quality per oocyte. Now, in terms of fertilization rates, fluctuation rates, reploidy rates, implantation rates, etc. Actually, when we review the available data, that association is not apparent. And decreased ovarian reserve per se, in most cases, does not explain the cause of infertility. So, from a diagnostic standpoint, an ovarian reserve test is not required. However, when someone does a pelvic ultrasound, you obviously see the antral follicle count. It may be on the lower side, but I don't think it justifies terrorizing the patient or blaming the woman just because she has low number of oocytes, follicles. It doesn't mean her oocytes are of lower quality, and that is necessarily the reason for the infertility problem they're going through. So, diagnostic standpoint, no indication for ovarian reserve assessment. Planning management is a different story. I'll come to that later. So, about tubal factor. Imaging studies are required. We can't see normal tubes. And HSG, the former standard of care, it seems the new sonographic contrast, hysterocontrast sonographic assessment of tubal patency provides us equivalent results when done properly. So, strong recommendation, you can choose any of them depending on your clinical conditions. And the selection depends on yours and patient's choices. In settings where these are costly or not easily accessible, in the absence of a risk factor for tubal occlusion, like history of pelvic surgery, in presence of severe endometriosis, you can use a chlamydia antibody testing, which would be the most common reason for tubal blockage in the absence of these other risk factors, as a screening test to identify which woman would require an imaging test for the tubes. So it depends on your clinical condition. But if there's a risk factor for tubal occlusion, then chlamydia antigen testing is not recommended. We need visual demonstration of tubal passage by one of these methods. Uterine factor. Uterine anatomy should be normal, and a proper vaginal ultrasound shows us all relevant aspects of uterine anatomy. If you have access to a 3D vaginal probe, it's easier to see, it's easier to show someone else. It can be preferable, but you wouldn't need additional imaging methods unless there's an indication of suspicion. And if the ultrasound assessment is normal, there's no need for routine assessment of cavity like saline infusion, hysteroscopy, etc. But if there's a risk factor for intracavitary problems like history of pregnancy losses, intracavitary instrumentation, then it's a different story. It should be a case-by-case basis, but routine diagnostic hysteroscopy or routine saline infusion sonography are not recommended in the absence of risk factors and a normal ultrasound assessment, proper ultrasound assessment of the uterus. A routine diagnostic laparoscopy is not recommended, but we think the evidence is strong in that regard. And is there any additional female lower genital tract tests that could be required today? Don't see a role for the postcoital test. And while vaginal, possibly cervical or uterine microbiota may play a role, the available evidence is short of showing it. The optimal diagnostic of testing method is not agreed upon. So it could be done in a research setting, but for directing clinical practice, we strongly recommend against microbiome testing for explaining the etiology of infertility or planning any treatments for that regard. For the male, as the definition of unexplained infertility requires a normal WHO semen analysis, then if the coital function is normal as reported by the couple, there's no need for testicular imaging or further examination. There are a variety of sperm and semen tests that are being actively marketed or used. You come across them in most meetings. Research setting aside, for routine clinical practice, we recommend strongly against anti-sperm antibody testing, sperm DNA fragmentation, sperm chromatin condensation test, or sperm aneuploidy testing, or male hormonal testing, or HPV testing, or a microbiological analysis of the seminal fluid. So academically, they can be all discussed, but currently available evidence does not suggest a benefit for directing clinical management, so they're not indicated for the diagnosis of unexplained infertility. Any additional tests, autoimmune tests, we do not recommend to explain the etiology, either thyroid antibodies or anti-sperm antibodies. The recommendation about celiac disease is there are studies suggesting that couples with unexplained infertility, female partners, may be more likely to have celiac disease. It's a very simple test. It may be low yield or high yield depending on the population, but it may be considered if this questioned and offered to the couple, not to treat their infertility, but to identify an accompanying problem. And the TSH measurement, as long as the patient is ovulatory regularly, there is no indication for TSH testing, but in most guidelines, a preconceptional TSH testing to identify to diagnose obscure hypothyroidism, which may affect fetal development, is good clinical practice. That's why we said it's a good practice point to do a TSH measurement in any woman contemplating pregnancy, regardless of fertility, infertility status, or the planned route of action. But if TSH is normal, we don't think additional tests, either hormonal or imaging, is required. Thrombophilia is irrelevant in the context. No tests are required. We recommend strongly against them. Oxidative stress tests may be relevant for research. Anything can be relevant for research. But measurement of oxidative stress or the overall inflammatory status of the female partner is not recommended for clinical practice, routine clinical practice. While in the future, I strongly think genetics will explain most of the unexplained infertility, but at the moment, from a therapeutic or diagnostic perspective, it's not recommended routinely at this stage. And testing for vitamin D is not recommended to explain the etiology of infertility problem. Again, in a regularly ovulatory woman, there's no need to do a prolactin test. And BMI, again, is part of physical examination and preconception assessment. It's good clinical practice to measure BMI. So here's the diagnostic summary: menstrual history, uterine anatomy assessment with preferentially 3D, but mainly with ultrasound. A tubal passage should be assessed with HSG or HICOSI, and the semen analysis should be assessed using WHO criteria. Now, how to manage a couple with unexplained infertility after these assessments? The first thing is, pregnancy and live birth requires the healthy egg and healthy sperm. It doesn't happen in every cycle. While 12 months are required to make a diagnosis, just hitting the 12-month benchmark does not mean this couple has no other chance of spontaneous pregnancy. So expected management can be considered in based on the couple's prognosis, which can be calculated by the Huno model, which is freely available on the internet. But in general, when intervention is justified, required, or by definition unexplained infertility per se, the first-line treatment that can be offered to any couple, is discussed with any couple, is ovarian stimulation with intrauterine insemination. Under the age of 40, nobody is ruled out directly. And there's strong evidence behind this, multiple RCTs showing that ovarian stimulation with IUI increases the chance of pregnancy in a certain time period. It makes it faster. And we didn't mention the ovarian stimulation protocol, but most parts of the world, strict cancellation criteria in some form are employed. The risk of multiple pregnancy is important in IUI cycles, ovarian stimulation IUI cycles. Once you limit the number of growing follicles, you can use oral antiestrogens or gonadotropins. If you're using gonadotropins, we should be particularly cautious about ovarian hyperstimulation and multiple pregnancy. Low-dose regimen, low-dose step-up regimens with proper monitoring is recommended. IVF is not necessarily better than IUI. It depends on how you compare how many cycles of ovarian stimulation IUI versus how many IVF cycles, or how long a period for spontaneous pregnancy attempts. So that's why it's conditional. It's not necessarily prioritized. So IVF as a first or second choice should be individualized. ICSI is not routinely recommended if the couple chooses to undergo an IVF. Mechanical surgical procedures. Intracavitary pathology like polyps or fibroids may affect fertility, may affect the chance of pregnancy. But as per the definition of unexplained infertility, if the initial ultrasound does not suggest the presence of these pathologies, routine imaging, routine further imaging is not recommended. Tubal flushing as a treatment is mentioned as conditional. Here's the reason. Studies consistently show if an oil-soluble contrast is used for HSG, it may increase the chances of spontaneous pregnancy for the cycle and even the next cycle, perhaps over a water-soluble contrast. But oil-soluble contrasts are more allergic, and HSG is mainly done as a diagnostic procedure, not as treatment, so the risks and benefits should be considered and discussed with the patient while for choosing the contrast medium if an HSG is to be done. About minimal mild endometriosis, we recommend it against routine diagnostic laparoscopy. But if the patient underwent laparoscopy for a different reason, the beneficial effect of ablation of minimal mild endometriosis is controversial. And then the patient would be diagnosed as having endometriosis, so wouldn't be a case of unexplained infertility so far. That's why we did not elaborate any further on that. You can refer to the X-ray endometriosis guideline. Clearly, there's no indication for endometrial injury or scratching to improve the chance of spontaneous pregnancy as a treatment for unexplained infertility. There are a lot of alternative medicine practices around the world, antioxidants, so it's conditional, it's not routine, we don't recommend testing for it, so necessarily, by implication, treatment will not be prioritized. Acupuncture is an umbrella term, it depends on how it is done. While few studies looked at it, the data is not strong enough to suggest it as a treatment. Nutraceuticals, psychotherapy, and they do not necessarily improve fertility, but psychological support is important and it may be recommended to the patients, and diet, exercise, and behavioral therapy. So good diet, exercise is recommended for anyone anyways, so they are included. And we should always consider the quality of life and not stress people and not subject them to a lot of unnecessary, unproven interventions. And here's the summary of the management: consider prognosis, then discuss expected management. If prognosis is good for a certain period, then IVF should be individualized. And if it's not good prognosis for spontaneous pregnancy, the first line would be over-stimulation IUI. And you see like 3 to 6, we say because there's no data. After a number of failed cycles, the couple can opt to go for IVF, and healthy diet, regular exercise is recommended for anyone. Behavioral and psychological interventions may be useful. So these are the research priorities we've come up with. Okay, so how to do best ART protocols, and how can we have better predictive models to assess the chance of spontaneous pregnancy and pregnancy with other interventions. So these are our conflicts of interests, and thank you for your attention. I'm happy to answer any questions.